Welcome to the deep dive.
Okay, let's face it. A lot of us have probably felt that, that gnawing, burning feeling in the stomach after maybe one too many drinks.
Yeah, definitely.
Today, we're going to get right to the heart of what's actually happening there. We'll look at what the experts know so you can get well informed without needing, a medical degree.
Exactly. Think of it as your kind of fast track to understanding that discomfort. We've got some really practical information today, straight from materials used to train family doctors right here in Singapore. So it's very focused on what you really need to know.
Right. Our mission today is pretty simple. Understand that stomach pain, particularly when alcohol's involved. What are the key things to look out for, and what are the first steps in getting it sorted? It's what doctors often call, I believe, suspected alcoholic gastritis.
That's the term, yes. And to make this really clear, we thought we'd start with a little scene, like a simulated visit to the doctor.
Yeah.
It's often the best way to see how this actually plays out in a real clinical setting. Okay, good idea. So picture this. You're in a family doctor's office. Our patient is, let's call him Mr. Tan Wei Keong. He's a 45-year-old sales manager.
I'll step into the role of the family doctor. Let's begin.
Mr. Tan, welcome. Please come in, have a seat. Tell me, what brings you in to see me today?
Doctor, I've been having this burning pain in my stomach. It's pretty much every day now for the past maybe few weeks. It seems to get worse after I eat, definitely much worse after I drink any alcohol. I've even been sick to my stomach a couple of times. Thrown up.
Okay, Mr. Tan, let's try and get a clearer picture of this burning pain. When exactly did it first start? Can you describe what it feels like, and where do you feel it most?
It started about 3 weeks ago, I think. It's a really uncomfortable burning. Right in the middle, sort of upper part of my stomach. It usually kicks in maybe an hour or two after I've eaten. But honestly, without a doubt, it flares up much, much more after I've had a few drinks. Sometimes it's even bad enough to wake me up at night.
Right. On a scale of 1 to 10, if 10 is the absolute worst pain imaginable, how bad would you say it gets? And apart from eating and drinking alcohol, is there anything else that seems to make it better or worse?
It really varies. Some days it's maybe a 5 out of 10, manageable but annoying. But other times, it shoots up to an 8, maybe even higher. Just stops me in my tracks. Those over-the-counter antacids like Gaviscon, they seem to take the edge off, but maybe only for half an hour or so. Then it just comes right back. I've also noticed maybe it feels worse when I'm stressed out at work.
Yeah. You mentioned alcohol makes it worse. Could you tell me a bit more about how much you typically drink, what kind of drinks, how often, and, roughly how much each time?
Slightly hesitant. Yeah, well, I do drink. It's part of the job, entertaining clients, all that stuff. Most evenings after work, I'll probably have maybe 6 to 8 cans of beer. On days when I have client dinners, which is maybe 2 or 3 times a week, it can be more. Sometimes 10 cans or even more. Just depends how the evening goes.
Right. I understand, Mr. Tan. Can I ask a few standard questions? Have you ever felt you should maybe cut down on your drinking?
Pause. I suppose so, yeah.
Have people ever annoyed you by criticizing your drinking?
Well, my ex-wife used to give me a hard time about it, yeah.
Have you ever felt bad or guilty about your drinking?
I do feel a bit bad sometimes, maybe the next day.
And have you ever felt you needed a drink first thing in the morning? Like an eye-opener, maybe to calm your nerves or get rid of a hangover?
Hesitates again.
Yeah.
Yeah. Sometimes I do need a drink in the morning to sort of steady myself, especially if it was a heavy night before. I get a bit shaky sometimes if I don't have a drink for a day or so.
Okay, thanks for sharing that. Have you had any other medical issues in the past? Anything similar to this stomach pain before?
Yeah, about a year ago, another doctor told me I had acid reflux. GERD, I think they called it. They gave me some pills, omeprazole. It did help, actually. But I stopped taking it maybe 2 months ago. I felt better and just, ran out of the prescription.
Right. Does anyone in your family have a history of stomach problems? Like ulcers, perhaps?
Yes, actually. My father, he had stomach ulcers when he was older.
Okay. Can you tell me a little about your work and maybe your life outside of work, Mr. Tan?
I work as a sales manager. It's pretty demanding, lots of pressure to meet targets, and like I said, entertain clients. Honestly, I sometimes feel like my job security kind of depends on drinking with them. I'm divorced, live on my own, and to be honest, I do get quite lonely sometimes. There's also, some financial stress, alimony, trying to make ends meet.
I see. And have you ever smoked? What about your general diet?
No smoking. I quit about 5 years ago. My diet, well, it's probably not the best. I often eat out because of work, sometimes grab food from hawker centers. Probably not the healthiest choices.
Okay. Have you noted any significant weight loss recently without trying?
Now that you mention it, I think I have lost a bit of weight, maybe 4 or 5 kilos. My clothes feel a bit looser.
And when you've been sick, have you seen any blood or noticed any black tarry bowel movements? Any fever?
No, when I vomited, it just looked like food. No blood that I saw. And no black stools. No fever either. My appetite, it hasn't been great, probably because eating sometimes makes the pain worse.
Okay, Mr. Tan, thanks for all that information. I'm just going to do a quick physical examination now, focusing on your stomach area. Could you lie down on the examination couch for me? Pause for exam simulation.
All right, I'm just gently pressing here. I'm feeling some tenderness right here in the upper middle part of your abdomen. Does that hurt when I press there?
Simulating discomfort. Oh, yes. Yes, that's definitely where the pain is.
Right. Okay, Mr. Tan, you can sit up now. Based on everything you've told me and what I found during the examination, the most likely reason for your stomach pain seems to be related to the effects of alcohol on your stomach lining. We often call this suspected alcoholic gastritis.
Gastritis.
However, it's important we also keep other possibilities in mind. Things like a return of your previous peptic ulcer disease, or perhaps GERD flaring up again. And we should also consider things like inflammation of the pancreas, which we call pancreatitis, although that usually causes more severe pain, or even a condition called non-ulcer dyspepsia, where there's pain but no obvious ulcer.
So what happens next, doctor? I'm actually quite worried. Could it be a serious ulcer? Or maybe my liver is damaged from the drinking. And how am I supposed to just stop drinking? My job really feels like it depends on it.
Those are very understandable concerns, Mr. Tan, and important ones. So to get a clearer picture, especially regarding your liver and ruling out other issues, I'd like to order some initial blood tests. This will include a full blood count. Sometimes alcohol use can cause changes there, and definitely liver function tests to see how your liver is doing. We'll also check your kidney function. We might also consider testing for a bacteria called H. pylori, as it's a common cause of stomach ulcers and can coexist with this. At this stage, though, we probably don't need to jump straight to an endoscopy that's the camera test looking inside your stomach, mainly because you don't have any of those more serious red flag symptoms we talked about, like blood or significant weight loss beyond the few kilos.
Okay, blood tests sound all right. What about medication? Those antacids I've been taking, they only help for a little while. I was kind of hoping for something stronger. Maybe like that omeprazole I had before. It seemed to work.
Yes, absolutely. We can definitely restart you on omeprazole. That should help significantly with the burning pain by reducing stomach acid. However, and this is really important, Mr. Tan, the most crucial thing in the long run is to address the alcohol consumption. I completely understand your concerns about your job making it difficult, but even reducing the amount you drink can make a huge difference to your stomach healing and your overall health. We can discuss some strategies for cutting down, maybe setting some realistic goals, and there are resources available, support services that can help if you're finding it tough to manage on your own. We also need to perhaps look at your diet. Try to avoid spicy or very fatty foods for a while.
Okay.
So the plan is blood tests, restart the omeprazole, we talk about strategies for alcohol reduction, and maybe some dietary tweaks. We'll schedule a follow-up appointment in, say, 2 weeks to see how you're doing and discuss the results of your blood tests. Of course, if your pain gets much worse or if you start vomiting blood or have those black bowel movements, please seek medical attention immediately. Does that sound okay?
Okay, doctor. I understand. The drinking and my job, it feels like they go hand in hand sometimes, but okay. I'm willing to try. I want to feel better.
Thank you for being so open with me, Mr. Tan. It's the first step. We'll work through this together.
That concludes our consultation for today.
Okay, well, that was our simulated doctor-patient interaction. What were your initial thoughts on how that went? What stood out?
Well, I think it really highlighted some crucial aspects, didn't it? Mr. Tan presented with those, classic indigestion symptoms, and the link to alcohol became pretty evident quite early on. Although, as is often the case, there was that initial hesitation, that slight defensiveness maybe, in fully disclosing just how much he was drinking.
Yeah, you could sense that.
But the doctor in the scenario, I think, did a good job of gently probing, asking more about the alcohol use using those cage questions, and also screening for those key indicators of potential alcohol dependence, like the morning drinking and the shakes.
Absolutely. And it really showed that it's so important not just to treat the stomach pain symptomatically, but to really dig into the person's lifestyle, especially their alcohol intake. And also their broader life context, right? The job stress, the feeling of loneliness he mentioned, all of that can play a part.
Exactly. It's never just one thing, usually. So let's take a deeper dive now into this condition itself, alcoholic gastritis. So at its core, what is it? It's basically an inflammation or sometimes even erosion, like a wearing away of the stomach lining that's directly caused by alcohol. We generally see it in sort of two main forms. There's acute gastritis, which often happens after a bout of heavy drinking, like a binge. And then there's chronic gastritis, which develops with regular heavy alcohol use over a longer period.
Okay, so how does alcohol actually do that? How does it cause this damage to our stomachs? It sounds like more than just simple irritation.
Oh, it is. It's quite complex, actually. Alcohol is directly toxic to the cells that line the stomach. So think of the inside of your stomach having this protective layer, almost like a non-stick coating, right? Made of mucus and bicarbonate. Its job is to shield the stomach wall from the really harsh acid that digests our food. Alcohol basically disrupts this barrier. It breaks down that protective layer. And then, initially, in some people, alcohol can actually trigger an increase in stomach acid production. So you've got more acid attacking a less protected lining. Plus, it interferes with the body's production of substances called prostaglandins. These are really vital for maintaining the health and repair of the stomach lining. And on top of all that, it can even mess with how the stomach muscles work, how they move food along. So it's a multi-pronged attack, really.
Wow, okay. It's hitting the stomach from several different angles then.
Yeah.
You mentioned it's common here in Singapore. Can you give us a sense of just how widespread this issue is?
It is quite common, yeah. I mean, given the levels of alcohol consumption in many populations, including here, alcoholic gastritis is definitely a frequent reason why people end up with dyspepsia, that's the general term for indigestion, and why they seek medical help, both in GP clinics and sometimes in A&E departments. Getting precise numbers is always tricky, but we know indigestion itself affects a huge number of people, and alcohol is often a key modifiable factor.
And the risk factors. Is it just about how much you drink?
How much and how often are key. Drinking more than, say, 4 standard drinks a day for men or more than 3 for women significantly increases the risk. Binge drinking is also a major factor. But other things can compound the problem, too. Concurrent smoking, regularly using NSAID painkillers like ibuprofen or naproxen, having an underlying H. pylori infection, high levels of stress, and even just having a poor diet. All these can make the stomach lining more vulnerable to alcohol's effects.
Right. So those symptoms that Mr. Tan described, that burning pain in the upper stomach, worse after drinking and eating, the nausea, the vomiting, those are all pretty typical signs then.
Exactly. Those are the classic ones. The burning epigastric pain, the clear link to alcohol and sometimes food intake, the nausea, occasional vomiting, sometimes, as you mentioned, even with streaks of blood, though thankfully not in his case initially. Other common symptoms include loss of appetite, feeling full really quickly after starting to eat. We call that early satiety bloating, belching. And importantly, as we saw with Mr. Tan mentioning needing that morning drink and feeling shaky, symptoms of alcohol withdrawal can sometimes overlap or be present alongside these gastric issues.
And on the physical exam, like in the role play, that tenderness in the upper middle part of the abdomen, the epigastric region, that's a key finding too.
Absolutely. Epigastric tenderness on palpation, when the doctor feels the stomach, is a very frequent sign. If someone has been vomiting a lot, you might also see signs of dehydration. And yes, in someone who is potentially dependent on alcohol, you might observe other signs like fine tremors, or perhaps they seem anxious, just as we noted in our scenario. It's also worth remembering, though, that while signs of chronic liver disease aren't specific to gastritis, they might be present in individuals who have a history of long-term heavy drinking, so doctors look for those too.
Okay. Earlier, you touched on how doctors differentiate alcoholic gastritis from other stomach problems that might cause similar symptoms. Can you elaborate a bit on that? How do you tell them apart?
Yeah, this is where really listening carefully to the patient's story, the history, is so important. For example, with a peptic ulcer, the pattern of pain might be different. Sometimes, particularly with duodenal ulcers, ulcers in the first part of the small intestine eating can actually relieve the pain, at least for a while. Also, ulcers are very often caused by that H. pylori bacteria or the use of NSAID painkillers.
Right.
With GERD, or gastroesophageal reflux disease, the main symptoms are usually heartburn, that burning feeling rising up into the chest, sometimes into the throat, and regurgitation like acid or food coming back up. Non-ulcer dyspepsia is kind of a diagnosis of exclusion. It's when someone has these persistent stomach symptoms, but investigations like endoscopy don't find any clear structural cause like an ulcer or inflammation.
I see.
Then there's pancreatitis inflammation of the pancreas. This typically causes very severe abdominal pain, often described as boring through to the back, and blood tests would usually show significantly elevated levels of enzymes called amylase and lipase. Gallstone problems often cause pain more in the upper right side of the abdomen or sometimes the epigastrium, and it's characteristically triggered by eating fatty foods. And of course, the one we always have to keep in the back of our minds, especially in older patients or those with alarm symptoms, is gastric cancer.
Which really brings us back again to the importance of getting that detailed alcohol history. You mentioned Mr. Tan's initial defensiveness. It's not always easy to get an accurate picture, is it?
No, it isn't. It's absolutely crucial, but it can be a really sensitive topic. Patients may underreport, sometimes significantly. So we need to ask specific, non-judgmental questions about the types of alcohol, the frequency of drinking, and the typical amounts consumed on drinking days. Using screening tools like CAGE, those 4 simple questions, cut down, annoyed, guilty, eye-opener is really valuable for quickly identifying potential dependence. The key is building rapport and taking a non-judgmental, empathetic approach.
Makes sense. And those alarm features, the red flags you mentioned that mean maybe something more serious is going on, can you just list those key ones again for us?
Sure. These are the signs that really necessitate further investigation, usually including that camera test, the endoscopy. So key red flags are new onset of dyspepsia symptoms in someone over the age of, say, 50 or 55, depending on local guidelines. A family history of cancer in the upper gut, like stomach or esophageal cancer. Persistent vomiting, especially if it's forceful. Significant and unintentional weight loss, often defined as more than 5 or 10% of body weight. Difficulty swallowing, which we call dysphagia. Pain on swallowing, adynophagia. Signs of anemia like unexplained tiredness, shortness of breath, or looking pale, feeling a lump or mass in the stomach area when examined. And finally, any evidence of bleeding, like vomiting blood, hematemesis, or passing black tarry stools, melena.
Okay, got it. And Mr. Tan didn't really have those initially, apart from maybe the weight loss, which needed clarifying.
Exactly. The weight loss was noted, about 4 to 5 kilograms, which warrants attention and follow-up, but he didn't have the other major red flags at that point.
So what about investigations? The blood tests that were suggested for Mr. Tan, what would those typically show in someone with alcoholic gastritis?
Right, so we'd often order a full blood count, or FBC. This might show an increased MCV, that stands for mean corpuscular volume. It basically means the red blood cells are larger than normal, which can be a sign of alcohol's effect on bone marrow or sometimes related folate deficiency. We'd definitely check liver function tests, LFTs. Enzymes like ALT and AST might be raised, but GGT gamma-glutamyl transferase is often particularly elevated and is quite sensitive to recent or ongoing alcohol use, indicating some liver involvement or stress.
Okay.
We'd also check kidney function and electrolytes, especially if there's been vomiting, to check for dehydration or imbalances. And as we discussed, testing for H. pylori is often a good idea, using something like a urea breath test or a stool antigen test, because treating it, if present, is important. But critically, without those alarm features, an endoscopy isn't usually the first step in a primary care setting like the one we simulated.
Right. And that leads us neatly into management, it sounds like. Overwhelmingly, the most important thing is to tackle the alcohol use itself.
Exactly. That is the cornerstone. You can give medications like omeprazole to soothe the symptoms and help the lining heal, but if the underlying cause, the excessive alcohol consumption, isn't addressed, the problem is almost certain to come back or even get worse.
So how do doctors approach that conversation?
It involves assessing the patient's readiness to change. Are they thinking about cutting down? Are they ready to take action? And then using techniques often based on motivational interviewing. There's an acronym sometimes used: FRAMES, feedback, giving personalized feedback about risks; responsibility, emphasizing the patient's own responsibility for change; advice, giving clear advice to change; menu, offering different options for change; empathy, showing understanding; and self-efficacy, building confidence in their ability to change.
That sounds like a good framework.
It is. For individuals who show clear signs of alcohol dependence, like Mr. Tan potentially did with the morning drinking and shakes, we also need to carefully manage the risk of alcohol withdrawal. Mild withdrawal can sometimes be managed as an outpatient, but more severe withdrawal needs inpatient care, often involving medication like benzodiazepines. And giving thiamine, which is vitamin B1, is crucial to prevent serious neurological complications like Wernicke's encephalopathy. And crucially, knowing when and how to refer to specialized addiction services, like NAMS, the National Addictions Management Service here in Singapore, is vital for ongoing support.
Okay. And for the immediate stomach symptoms, while addressing the alcohol, what's the usual go-to treatment?
Proton pump inhibitors, the PPIs like omeprazole or pantoprazole, are generally the first-line medication. They are very effective at reducing stomach acid production, which gives the inflamed stomach lining a chance to heal. We typically prescribe them for a course of maybe 4 to 8 weeks initially.
Are there alternatives?
Yes, H2 receptor antagonists, or H2RAs, like famotidine, are another option that reduces acid, though they're generally considered less potent than PPIs. Over-the-counter antacids, like the Gaviscon Mr. Tan was using, can provide quick, temporary relief by neutralizing the acid already in the stomach, but they don't heal the underlying inflammation. There's also medication called sucralfate, which can form a protective coating over the stomach lining, but the evidence specifically for its use in alcoholic gastritis isn't as strong as for PPIs. And of course, if H. pylori infection is confirmed, it needs specific eradication therapy, usually involving a combination of antibiotics and a PPI.
Makes sense. What about other lifestyle changes beyond just the alcohol?
Yeah, definitely important too. It's crucial to avoid other things that can irritate the stomach lining. That means stopping smoking, if the person smokes, and limiting or completely avoiding NSAID painkillers, things like ibuprofen, diclofenac, naproxen. Paracetamol is generally safer for pain relief in this context. It can also help, especially initially, to be mindful of diet, avoiding very spicy foods, very fatty foods, maybe even caffeine or very acidic foods if they seem to trigger symptoms. Eating smaller, more frequent, and perhaps blanderer meals can be easier on the stomach than large, heavy ones. And ensuring adequate nutrition is key, especially if someone's appetite has been poor or their diet restricted due to the pain.
And you mentioned the bigger picture, too.
Absolutely. We can't overlook managing any underlying stress or psychosocial factors, like in Mr. Tan's case, addressing the work stress, the loneliness. These things matter for overall well-being and might influence drinking patterns. Treating any coexisting mental health conditions like anxiety or depression is also really important.
Okay. And just to summarize the referral criteria again, when should someone experiencing these kinds of symptoms really seek more urgent or specialist medical help?
Right. So urgent referral, usually to the emergency department, is needed if there are any signs of significant bleeding, vomiting blood, black stools. Also, if you suspect a perforation, which would cause sudden severe abdominal pain, severe dehydration from persistent vomiting, if you suspect severe pancreatitis, or if someone is experiencing severe alcohol withdrawal symptoms like seizures or delirium tremens.
Okay, those are the emergencies.
Yes. Then, for less urgent but still necessary specialist review, usually with a gastroenterologist, you'd refer if symptoms persist despite initial treatment and reducing alcohol intake, or if the diagnosis remains unclear after initial tests, or, of course, if any of those red flag symptoms we discussed earlier are present.
So the key takeaway here really seems to be that dealing with what might seem like just simple stomach pain after drinking requires a really comprehensive, multifaceted approach. It's about digging deeper, understanding the huge role alcohol plays, being able to differentiate this from other conditions, knowing those crucial warning signs, and importantly, addressing both the immediate discomfort and the underlying alcohol consumption pattern.
Exactly. It really highlights how often these seemingly straightforward complaints, I've got indigestion, can have much more complex roots. And it makes you think, doesn't it, about the importance of asking the right questions, maybe sometimes the uncomfortable questions, and not just taking things at face value. Might even prompt you listening to think a little about your own habits and how they could potentially be affecting your health, even in ways you hadn't considered.
That's definitely a thought worth considering. If you've had similar experiences yourself, or perhaps have questions that came up listening to this, we'd genuinely like to hear from you. It's a conversation that can sometimes feel a bit awkward, maybe, but it's so important to have. Thanks for taking this deep dive with us today.